The first one we'll talk about is AROM. AROM is the artificial rupture of membranes. It's also called an amniotomy. Most physicians will use an amnio hook in order to break the bag of water. And some use a finger condom that has a needle at the end, or sometimes forceps are used. For the nurse, when this is happening, it can be used to stimulate labor. It can be used to make labor progress faster in a woman who is getting an oxytocin induction, or just to speed up labor. Now, we want the head to be engaged before this procedure is done because we don't want to risk a cord prolapse. So as soon as this procedure is done, the nurse already has her baseline fetal heart tones, and as soon as it's performed, we see the fluid come out, and then we will immediately check fetal heart tones to make sure that there's no changes or abnormal or non-reassuring fetal heart rate patterns after that. We will monitor that heart rate for a whole full minute afterwards. We will also document the color, quantity, description, and odor of the amniotic fluid, and then we will change her pads and put dry ones underneath her. Since she's going to continue to leak fluid, we'll keep changing her pads as they become saturated. We want to monitor temperature. So now her membranes are ruptured, she's at risk for infection, and we will monitor her temperature every 2 hours and report anything more than 100.4. Now we'll move on to meconium amniotic fluid. So when you rupture the membranes, the fluid comes out and you make the observation that it's meconium stained. It will be a green tint instead of clear. Now, this is worrisome for the baby more than the mother. So it can mean a couple of different things. It happens as the baby matures, so closer to post dates. A baby that is underneath stress will have variables or late decels, and they often will have a meconium poop before delivery. The meconium fluid can be thick or thin. So as the baby has that bowel movement inside the uterus, it can dissipate into the fluid and be mixed, and that's where you get that green tint from. But it can be very thick, or it can mix really well and become thin. It's the thick kind that is more worrisome, so as the baby takes the breath, it goes into the lungs and it can stick. We don't want that to happen. So what the nurse will do is alert the neonatal team. We will prepare for a bad baby. So a bad baby in the nursing world is considered a baby who's going to come out and need resuscitative efforts. So it causes respiratory distress in the newborn and will monitor for infection in the baby. Now before delivery, if we see that the baby is having variables or decels in the presence of meconium, we will give the mom oxygen, turn her on her side if she's laying on her back, stop oxytocin if that's being infused, and we will give IV fluids if mom is hypotensive. Because if mom is hypotensive, we're not going to be able to perfuse well to the baby. So we don't want her to have really low blood pressure. We want to suction the baby as soon as possible and hopefully before it takes its first breath. We want to deep suction the baby. Okay, we want a deep suction with a catheter, just like the same catheters we use to do trach suctioning, but baby size. We will suction the baby deeply so we can get as much as that meconium stained fluid out of the lungs and lung tract as much as possible, so we can help prevent that meconium aspiration with the first breath. The most common method of induction or augmentation of labor is using Pitocin. It is a very common method of labor induction, and it helps begin the process. It helps to stimulate cervical effacement, dilation, and contractions. With the augmentation, will help to stimulate hypotonic contractions to be more effective. We may use induction for women who are post-term dates, if they've had a prolonged rupture of membranes, they have pregnancy-induced hypertension or eclampsia, diabetes, because we don't want the baby to get too big, chorioamnionitis, if they have an infection, then we need to deliver the baby. A fetal demise, and hypotonic contractions, and that would mean an augmentation at that point. The women do need to have a good Bishop score where their cervix shows some evidence that it's favorable for induction. Women who should not be induced with Pitocin include a fetal malpresentation, such as a breech delivery, a person who has an active herpes infection, a person who already has regular uterine effective contractions, a non-reassuring fetal heart rate pattern, placenta previa, an unexplained bleeding, and previous C-section. Now, with Pitocin complications, there are some risks. So the potential risk for C-section doubles for primogravidas versus the multigravidas. So they have a 50% more chance of ending up with a C-section. And this is mainly because their cervix does not take very well to being forcefully induced. And with a multigravida, their cervix has already been stretched out, it's done it before, so it's quite easier to induce a multigravida. It also will cause a hyperstimulation of the uterus. And with the hyperstimulation of the uterus, then we have a contraction and we don't have a good relaxation period in between contractions. That's hyperstimulation. They can last longer than 90 seconds, and that is not good. That means our baby is not getting good perfusion in between. So hyperstimulation, if that occurs, we stop the infusion. The other thing that Pitocin can do is make the mom retain water. So water retention, and that will cause hyponatremia, confusion, convulsions, and even coma. It can also lead to congestive heart failure and death if not monitored. Now, as you know, women who are in labor get a lot of IV fluids. Depending on how long they've been in labor, they're having a continuous infusion of something, normal saline, LR, or Pitocin saline mix, and it's continuously infusing. So as a nurse, we have to watch for this water retention. So what do? Well, you check their legs for swelling. You check their eyes and nose need to be accurate. You need to look and make sure that they're having enough output that is equal to their input. And we need to watch their blood pressure. So we need to watch their breathing and for shortness of breath, lung sounds. So these are some risks that are real for Pitocin induction that we need to monitor for. Now we're going to talk about some other operative methods of delivery. The first one is a vacuum delivery. A vacuum-assisted delivery must be done by the RN, specially trained, and it is a suction cup that connects to the fetal head. A physician uses this instrument, and they puts the suction cup on there, and then the nurse may assist with pumping it up. So they'll pump it and give it the vacuum seal, and then the physician will use that to pull on the baby's head to help with the delivery. This may be used in cases where we need to deliver the baby fast because the heart rate is doing poorly with the baby, or mom is not pushing effectively and they have to get the baby out. So there's just a couple of different reasons why they would need to do this. It is a last resort type option. No one likes to use the vacuum device. It does create issues for the baby. It can create scalp trauma, which is common. It'll cause like the caput saccadium, where you have the hematoma on the top of the baby's head that crosses the membrane. Then you'll have they can have a subgleal or intracranial hemorrhage, and it can cause death in the infant. So it's very hazardous, and the infant will need to be checked out after delivery. The other one is forceps. And forceps are what the physician uses independently. As a nurse, we may just hand it to them. It is also used for similar instances. It's an instrument with a curved blade. It looks like salad tongs. It's more commonly used than the vacuum is. They they put it around the baby's face and they hook together, and then the physician will pull and help rotate the baby. So if the baby needs to rotate some, he'll use these things to help rotate the baby and to also help deliver the baby's head. This can cause lacerations for mom's vaginal wall, creates hematomas, other tears. This tool can also have an episiotomy, tear open farther. So similar things, you can see bruises on the baby's face, but we always use these things as a last resort.